Good evening, all. My screen is visible. Yes, I am audible.
Yes, sir.
My slides are moving.
No, sir.
Right?
Yes, sir. Yes, sir.
We will start the session. And before starting session, just I have a few questions. And I need the session to be interactive. So whatever right or wrong answers, please shoot your answers so that we can move on quickly. So don't waste time for me. And second thing is, what is the commonest problem you see in your admitted patients, not the OP patients? And among your admission patients, what is the commonest problem so you face? Any answers? Among admitted patients, what are the commonest problems you face?
Fluid overload.
How much percent? How much percent of admission patients will have fluid overload?
Ventilated patients.
Yeah, that's what I'm saying. How much percent? Among 100 admission patients, how many patients will have your fluid overload? 50%, 70%, 90%, 20%?
35 to 40.
Okay. Any other problems?
Hypokalemia.
Hypokalemia. Okay. So you are in the direction. So you want to mean to say dyselectrolytemia.
Yes, sir.
It could not be only potassium, it could be any sodium, calcium. So how much percent roughly you can say?
Sir?
How much percent of dyselectrolytemia you see in admitted patients?
Most 70% may have dyselectrolytemia.
Exactly. So what I feel is whatever problem you name, among all, dyselectrolytemia accounts for the majority. For admitted children, I'm not talking about OP children. So OP children will have fever, cold, cough, that's the common symptoms. But if among admitted children, you admit for what are the diagnoses? You admit for meningitis, you admit for pneumonia, you admit for UTI, you admit for seizure, you admit for whatever condition. They may have a one or two electrolyte disturbances. So why this much of dyselectrolytemia is seen in admitted patients? So there is some reasons for that. We'll discuss later. So that's why it's very important for us to know what is the cause for dyselectrolytemia, how we have to manage dyselectrolytemia, because that is a that much common problem. So we'll encounter in our admitted patients, admitted children. So we'll go through a case scenario. So we have two scenarios here. One scenario is a 5-year-old child with a known case of nephrotic syndrome. Now the child came with relapse, with edema and all. And we did routine investigations in that. So I'm not talking about what is the urine protein, what are the other things. I just am going, my concern is sodium here. The child sodium is 126. On the other side, you have 3-year-old child with right lobar pneumonia, and the child was on O2 and child was on full maintenance fluids because of his poor oral intake. And we checked his electrolytes as well, and his sodium was 128. So what do you feel is the cause for hyponatremia in these two children?
For 3 years old, mostly it is due to SIADH.
Okay. So in SIDS, what type of hyponatremia you have?
Euvolemic hyponatremia.
Good.
In 5 years old, that is hypervolemic because of nephrotic syndrome.
Hypervolemic hyponatremia. So how you are going to manage these two children?
Euvolemic hyponatremia, fluid restriction.
Okay. So it is very important to know what type of hyponatremia you are dealing with. Why you cannot just give sodium for all the hyponatremias? Sodium
There
is,
is not true hyponatremia.
there are two hyponatremia only. They are not spurious. All these hyponatremias are true only. Just you can give sodium. Why you thinking about what why hypervolemic, euvolemic, hypovolemic? Just give 3% NS or NS so that you can increase the sodium. Why you are underlying carb? What is the type of hyponatremia? Why very important in management of hyponatremia? So already which is hypervolemic. If keep giving 3%, what will happen?
More hypervolemic.
Yes, that is the main concern. So you should not make hypervolemic child more hypervolemic by infusing extra 3% NS, then it will drag more water and it will cause more hypervolemia. So that's why the management there is not infusing 3% NS, restricting the fluids. So you are asking the body to adjust the sodium accordingly. So there is excess of water apart from the sodium content. So you decrease the water and sodium will increase, concentration will increase. So that is the main principle here. That's why you should know what is the type of hyponatremia so that you can manage accordingly. Now we have a scenario. So this is a 5-month-old child, PSD and antifungal medications. So now brought with fever and worsening distress for past 2 days. And child had history of loose stools for 3 to 4 episodes per day. Child was on DBF, copper formula feeds as well. Now currently child was irritable. And there is no evidence of dehydration. Respiratory retractions are there, creps are there, VG is there. We did an X-ray showing hyperinflation, congestion, cardiomegaly. Otherwise, there's no shock. GVT was normal. This is what your electrolytes are.
Drug induced or furosemide induced.
Okay, so furosemide, what type of hyponatremia? There are only 3 types of hyponatremia: hypovolemic, hypervolemic, euvolemic.
Hypervolemic hyponatremia.
Okay, only one answer. Hypervolemic, confirm. Why you are telling hypervolemic?
CCF.
CCF. But previously Saktis are told it is diuretic individual. Diuretic will not cause hypervolemic, right?
Yes, sir.
So there is an add-on.
CCF is.
Yeah, CCF is causing hypervolemic, and you have diuretic use. So there is an add-on. So add-on hypovolemic, hyponatremia. Any other thing you want to add here? Child also had history of
Loose stools.
So what it will cause?
Hypovolemic hyponatremia.
Yeah, again, you have 2 causes for hypovolemic hyponatremia and 1 cause for hypervolemic hyponatremia. Is any other cause?
Diuresis will not cause that much hyponatremia.
It can cause.
Mostly it will cause hypokalemia.
No. In already in compromised sodium conditions, diuretics. One other reason for the hyponatremia is diuretics. We'll see the causes later. Diuretics will cause hyponatremia, there's no doubt in it. It can cause hypernatremia also. It depends on the kidney response. If it's causing more sodium loss to the kidney, it will cause hyponatremia. It is causing more water loss, it will increase sodium. It can cause, if it's dehydration child, it can cause hypernatremia as well. Is there any other cause we are missing here apart from this?
Secondary aldosteronism.
X-ray is giving the clue. The auscultation is giving the clue. X-ray and auscultation. Child is having worsening distress.
A condition because of right atrial fluid or this one volume natriuresis.
Child is having loose stools there. What is X-ray finding here?
Hyperinflation, congestion, and
Do
cardiomegaly.
you have hyperinflation CCF? What are the auscultator findings?
Acute
Hepsin.
lung.
Acute? Yeah, when you will have wheeze and hyperinflation, which conditions will have wheeze and hyperinflation in infants? Which
I
fever?
said left lung.
Bronchiolitis.
Yeah, bronchiolitis. What type of hyponatremic bronchitis can cause?
SIDH.
So it is a type of euvolemic. So in this particular child, we are seeing hypervolemic, euvolemic, hypovolemic, hyponatremia. But what you feel, what is the predominant cause here? Do you think hypovolemia is the predominant cause here? Do you think it looks more like hypovolemic hyponatremia from the examination and the history findings wise?
Hypervolemic hypernatremia, sir, because the child is not having any dehydration. So the probable cause is because of CCF, sir.
Exactly. So it's more of hypervolemic and euvolemic rather than hypovolemic based on the clinical examination. So how will you manage this child? We have three causes now. One is hypovolemia, one is euvolemia, one is hypervolemia.
Restriction of fluid.
Exactly. So if you think it is only hypovolemic hyponatremia because of loose stools and diuretics without examining properly, you will going to give the NS bolus or sodium infusions. But in this particular child, so you need to restrict the fluid. But what is the sodium here?
121.
Can you just keep restricting the fluid for sodium 121 without giving anything?
First, we will increase the sodium to more than 125, followed by restriction.
Exactly. But increasing 125, how you do?
By bialycards of 5% NSC, like 2 ml, 2 ml, 2 ml based on that.
So 3% NS you want to give 2 ml per kg. Not
Yes.
2 ml, 2 ml.
Sir,
3% NS, how you going to give?
5 ml per kg.
You want to give 5 ml. How much 1 ml per kg will increase?
1 milli equivalent.
And why you want to give 5 ml per kg? Your target is 125 only, right?
Yes, sir. For 4 hours, we will give.
Okay. So by that you are going to increase the pulmonary edema. Right? You are giving 3% NS, so it's going to increase the intravascular volume. Again, your lung congestion is going to increase. Distress is going to increase. Then you are going to put the child on CPAP or intubation. So how to prevent that?
Along with the sodium, also get furosemide.
Exactly. So never ever forget in hypervolemic hypovolemia, whenever you are giving 3% NS, you cannot give 3% alone. Always combine 3% NS with diuretics. So that is the funda. So I think with these two scenarios, we know what we are going to discuss today. So we'll see how things going to happen in hyponatremia and how carefully we need to manage this kind of children in the subsequent slides. So electrolytes are basically ionizable substances. They're dissolved in whatever fluid you have in the body, the plasma, interstitial, intracellular fluids. And basically, water and electrolytes are regulated mainly by homeostatic mechanisms, and they cannot be separated each other. So water and electrolytes should be combined with. Mainly sodium and water is inseparable. So they are together always. And how they're maintained normally is by your dietary intake and basically relation with your kidneys. So in any acute illness, say surgery or any pneumonia, you have affecting your volume of distribution of body fluids, so which can cause electrolyte disturbances. And once the child had got the illness, you're going to give number of medications. Even with medications, they're going to alter the electrolyte disturbances. So because all these things, any child getting admitted with you, there's a high possibility for getting an electrolyte disturbance. So you have to actually look for that. So because the electrolytes are the routinely done investigations for any semi-sick child to sick child. So why? Because you know that any acute illness is going to alter the electrolytes. Even before the illness child is taking regular amount of electrolytes out intake, but during the illness child may not take that much, and the underlying illness will disturb the volume of distribution of body fluids, and the medication you are going to give is going to order the electrolyte disturbances. So that's why any child getting admitted with you, try to get at least 1 based on electrolytes to see what is the number. Based on that, and then you have to see how frequently you're going to repeat the electrolytes. So whenever you encounter a dyselectrolytemia, what is the first question you're going to ask? The first question you're going to ask is the measurement is accurate? So whether I'm dealing with the this is the report which is correct or not. So there are many examples, many flaws in electrolyte measurements. So the calibration of the machine, starting the calibration machine, starting from sample collection, transport, this all things going to alter your electrolyte number. So that's why you need to see very carefully whether this abnormal report correlates clinically. Like your radiologist tells, always correlate the relative findings clinically. So you need to correlate electrolyte report clinically. So if you have a child with who is stable, just came for fever checks and fever for 4 days and very stable, taking orally very well, and you did an electrolytes routinely, and you got a report of sodium of 120, child is looking very absolutely fine, and there is no underlying problem, no pneumonia, nothing, no diarrhea. You should question yourself why this child had low sodium. Is it reliable? Whether I want to repeat it again? Is there any sampling error or lab error? So always try to correlate the abnormal electrolyte report clinically. If it clinically is fitting, fine. If clinically is not fitting, there's no underlying cause to suggest that electrolyte abnormality. So you need to take it with a pinch of salt and try to repeat it. Once you confirm it, this is a true electrolyte disturbance, then you have to question yourself, is that report is critical or non-critical? Like in the previous scenario, what you see in your sodium is 121. In the first scenario, sodium is 126. So second report is very critical to you. So you cannot think of what are the causes. So you need to start treating that electrolyte imbalance. In first scenario, you don't need to treat emergently. You can think what is the cause and then you can plan for that. But in second scenario, the 121 sodium is alarming. It's a critical value. So you need to try to correct it. Then simultaneously, you need to think for the causes. So once you started the critical value correction, then you need to think of the cause. Then the most important thing is whether the cause is acute or chronic. Because the corrections, how much fast you're going to give, depends on what is the chronicity. If it's acute, you can correct it little rapidly. But it's a chronic issue, you need to correct it very slowly because the body is already adjusted to that. So if you correct it very fastly, body cannot readjust again. So that way you have to give the time for the electrolytes to get corrected slowly. And the most important thing is you need to look for the sources of electrolytes what the child is taking. Whether the child is on IV fluids without any electrolyte sources, or child is taking orally, but what oral fluids is taking, whether he's taking only plain water. So like this kind of things you need to question yourself. And you need to, based on all these things, you need to formulate a plan for this child. So how safely I can correct this electrolyte? How safely? That's a very important thing. Sometimes you think, oh, this is sodium, okay, I have to correct it very. So you're thinking of correcting sodium, but you're not thinking about if I correct this fastly, what is going to happen for the child? So child is hypokalemia, I'm going to give fast correction of hypokalemia, child go for hyperkalemia and taking an arrest. So that's why you need to formulate a plan very carefully and safely so that you don't cause harm for the child. And the last important thing is when the child has multiple electrolyte abnormalities, so which you have to treat first, then what I'm going to treat next. That's what you need to formulate. So these are the 7 or 8 important questions you need to ask when you encounter a dyselectrolytemia. The first and foremost is whether this is the true disturbance. Once you live with true disturbance, you need to question yourself whether it's critical or non-critical. Critical, treat it first, then you think about the cause. So next question comes is what is the cause? Once you identify the cause, whether it's acute or chronic, then what is the source of electrolyte child is getting, and plan and safety approach. So these are the common questions you need to question when you see an electrolyte abnormality. Anything you want to add here, I can move on from here. Any other questions we can ask? Any other thing I forgotten here? This is what I thought. This is what I do commonly when I encounter dyselectrolytemia. Can you move on?
Yes.
Yes, sir.
So the first question here is the measurement is accurate? So I told previously itself, there's a lot of conditions. It could be sampling error, it could be lab machine error, so it could be patient-related conditions, some kind of problems in the children. They can predispose to electrolyte imbalances. So based on this, you need to think. So these are the common conditions where you get spurious electrolyte disorders. So for hyponatremia, if you have hyperlipidemia and already you given IVIG for certain kind of children, you can get hyponatremia, but it's not true hyponatremia. This kind of hyponatremia you can easily get identified if you repeat the sample with an ion electrode based method. Basically, it is nothing but your ABG. So if you have problem with the lab and you think that the child might not having true hyponatremia, and if you got a report of hyperlipidemia, to get true value, so you can repeat the same sample in an ABG machine where they do with a different method. So they can give the correct value. And for hypocalcemia, mainly related to the albumin binding. So in hypoalbuminemia, you can get spuriously low calcium. So you need to correct it. You need to have formulas for correcting for albumin calcium levels. And the most common electrolyte disorder, which is spurious, is potassium. You can have hypokalemia, you can have hyperkalemia, and hyperkalemia is the most common entity what we'll see commonly. It's basically because of in children, you're going to squeeze the sample. To get the sample, you're going to squeeze. So with that, you're going to damage the local tissue, and you can cause hemolysis, and adversely it will raise the potassium, but it's not a true hyperkalemia. So it is because of just release from the cells. And sometimes you have marked leukocytosis or thrombocytosis. They can lyse in the sample and they can release the potassium. So these are the basic examples where you can get pseudo electrolyte imbalances. Just you can take a screenshot and keep it with you. So whenever you got an electrolyte disturbance, just go through this, whether my patient is having any of these conditions which can predispose him for pseudo electrolyte disorders. So when you identify a pseudo electrolyte disorder, the most important thing is you should think that whether this child can have additional, I have a child with leukemia. The leukemia child, you think that leukemia child can prone for pseudo hypokalemia. But you also know that leukemia cells, when you're given prednisone, they will lyse. Once they lyse in the body, they can cause true hyperkalemia as well. So don't take it otherwise. So because I told today leukocytosis can cause pseudo hyperkalemia, and you got a report of sodium, potassium of like a 7.5, and child is having some ECG disturbances, tall T waves, then you cannot think that this child is leukemia, so this child can have pseudo hyperkalemia, and let me wait on this child. No. So you need to correlate clinically. The clinical findings are such a hyperkalemia, you treat it. If it's not findings like the child is not having any like underlying leukocytosis or thing, but just the child is very active and there's no reason for getting hyperkalemia, and on that children you got the report, then you need to think that whether I'm dealing with spurious electrolyte disorders. If clinically, like your ECG should be normal, child is not on potassium supplements. So this kind of children, you need to think of pseudo hyperkalemia, not on the other child is using potassium supplements and child is having ECG disturbances. So you cannot think of pseudo hyperkalemia. So these are the basic things when you should know when you're dealing with spurious electrolyte disorders. So always correlate clinically. Combine your electrolyte reports with clinical background. So next question is the result is critical. So in critical, you need to take the steps very cut in rapid manner. You cannot wait for the cause. What is the cause? I'll cut it slowly. So in that, you have a sodium, an asymptomatic child less than 120 or less than 125 with symptoms is very critical. You need to correct it rapidly. And if you have potassium more than 7 or any more than 6 with ECG changes or severe potassium hypokalemia less than 2 or less than 2.5 symptoms, these are the critical values. So you need to treat them very rapidly. And in case of hypocalcemia, child is having seizures or tetany, you need to correct it very rapidly. So these are the critical values where you need to take the action immediately. You cannot delay the action. And next important thing is what is the cause and what is the chronicity. So whether the cause, there are only three types of causes. One is inadequate intake or excess intake. Second thing is redistribution. So you say, what is the normal distribution of sodium and potassium in the body? Intracellular, extracellular?
Sodium is extracellular cation.
Okay. Potassium is?
Intracellular.
So, but some conditions can alter this balance. So they can redistribute the potassium and sodium accordingly. So it can cause abnormalities. And third important thing is losses. So one thing is decreased intake or excess intake. Other thing is redistribution. And third thing is losses. It could be low loss, or it could be high loss. So according to that, you can get hypo, hyper. And second thing is your last thing is your medications or disease which can cause alternate homeostasis. And chronicity is very important. So because in acute conditions you can correct it rapidly, in chronic conditions you need to correct it very slowly. So after this you need to follow a plan and safety approach. Whether I want to go for IV correction or oral correction. Whether I have to give rapid correction or slow correction. And what other drugs you have to use for the correction. So this is what the plan you need to formulate at the end. Based on all these things. So IV or oral, rapid or slow, and what are the drugs I have to choose. So what is hyponatremia? So hyponatremia is sodium less than 135. The most important reason why you have to deal with hyponatremia is, so it will cause your damage to neurological system, mainly by shifting the fluids. So what will cause in the brain hyponatremia?
Edema.
Why it is caused edema?
Sir, osmolality will change now. Earlier sodium was outside high. So now hyponatremia is there. So outside iron concentration is less. So fluid will shift.
Outside high
Low
concentration.
osmolar to high osmolar shift.
Exactly. So the body will not see how much is the volume this side, that side. It's only going to see what is the osmolarity this side and that side. So what it's going to do? It's going to just keep the osmolarity difference like that, and it's going to equilibrate the osmolarity.
Equilibrize.
So that is the point behind all your electrolyte imbalances, especially sodium. The body always try to equilibrate the osmolarity on either side of the semi-permeable membrane. So when you have hyponatremia, what is the osmolarity in your plasma?
Low osmolar.
Low osmolarity. So now body is going to try to increase the plasma osmolarity, or it's going to decrease the other side tissue interstitial osmolarity. So you want to maintain equilibrium, right? So you are
It will increase the osmolarity by shift of free fluid in from extracellular compartment to intracellular compartment.
okay. So that
Or either of that ones.
oh, that's what I'm telling. It's not happen like that.
Yes.
So water will move from which osmolarity to which osmolarity?
Low osmolar to high osmolar.
Smaller to higher smaller.
Yeah, less concentration to more concentration, but because that's what I'm telling. So you need to increase osmolarity on this side, not by shifting water. You cannot shift the water from intracellular to extracellular and increase the sodium. So the body has to build up the sodium by some other means, like decrease sodium excretion in the kidneys or increase sodium intake. But already that all happened. The homeostasis already happened, and it's failed to decrease, maintain the sodium. That's why you have low sodium. So all the homeostatic mechanisms are already lost. So your body cannot increase osmolarity on the plasma side. So that's why you need to going to decrease the osmolality on the opposite side. So that's why your water is going to shift from the plasma to the cellular side. So you'll have cerebral edema. Is it clear what I'm telling?
Yes, sir.
Yes, sir.
Just think about osmotic equilibrium. That is the most important statement you need to remember. Once you understand that what is osmotic equilibrium, how the body is going to act, then it's easy to understand. So you cannot increase sodium on plasma side because all the homeostatic mechanisms are lost. After the failure only, you get hyponatremia. So the water cannot come this side. The water has to move from this side to that side to maintain the osmotic equilibrium. So there you get the cerebral edema. Say now your cells are swelling. What body will try to do? It can allow severe cerebral edema to cause coning and death.
So brain will generate idiogenic osmoles so that it will further reduce that shift of fluid from the
Just wait.
plasma.
What brain will do?
Generate idiogenic osmoles.
Okay, if you generate idiogenic, what will happen? What will
It
happen?
will reduce the
No. Just think. Calm. If you generate idiogenic osmoles intracellularly, so what will happen to your intracellular osmolarity?
Increase.
If you increase intracellular osmolarity, what will happen to the fluid shift?
further increase.
More fluid will be shifted.
That's not the mechanism. So what the cell has to do?
To
Idiogenic,
lose solutes.
what it has to do?
To lose solute.
Exactly. So you need to decrease the osmolality on intracellular side. So you need to exclude some of the osmoles from the cell. What the osmoles easily we can exclude?
Sodium.
Sodium you cannot exclude. That already done. That is already gone. Your potassium, sodium potassium pump will not exclude sodium out until unless you have energy and potassium outside. So you have proteins, you have phosphorus. These are the osmoles which cannot be useful for the cell much. So it can be easily lost. So if you develop hyponatremia slowly, the body will try to adjust the osmolality by excluding some of the osmoles out of the cell so that you can have osmotic equilibrium. So your fluid will not shift much, so you don't develop cerebral edema. So that is the reason. So in chronic patients, they will have very less symptoms. If otherwise you are developing a acute hyponatremia, they'll have so much symptoms. But in chronic hyponatremia with sodium of 111 also, they will keep walking. So that is what the body will try to adjust, acclimatize. Now, if you have a chronic hyponatremia chain, and what you are doing is you are giving 3% rapidly. So you started giving 3%. So what is going to happen in the plasma osmolarity?
Increases.
Increases rapidly. Now, compared to the plasma osmolarity, what is the cell osmolarity in chronic hyponatremia when you are giving 3%?
Hypoosmolar. So rapid shift.
So what will happen now?
Shrinking, cerebral shrinkage.
Shrinking. So water in the cell will shift to the plasma. It will shrink. So it can lead to osmolysis, myelolysis.
Central pollen.
So understood, it's clear what I'm talking? So this is
Yes, sir.
mainly to maintain
Yes, sir.
osmotic equilibrium. The principle behind your hypo and hypernatremia management is you need to maintain osmotic equilibrium. So if you understand this concept of osmotic equilibrium, it is easy to understand how to correct hypo and hypernatremia. Clear? Can I move from this?
Yes.
So any sodium less than 125 or rapid fall can trigger the symptoms. And any sodium less than 120, they can have severe symptoms like seizure, subtension, lethargy, and headache. If it's chronic hyponatremia, that means developing more than 24 hours, they will have less symptoms because of cerebral adaptation. So they will not think, you don't think that they have this much low sodium based on the symptoms. So that's why if you have a asymptomatic change with low sodium, think of chronic hyponatremia. Never think of acute hyponatremia. And we have symptomatic child with moderately low sodium, like 120, 121. Think of acute hyponatremia. So these are the common causes of hyponatremia. So you can see here. So you classify hyponatremia into true hyponatremia, where they have low serum osmolality. This is called true hyponatremia. To measure your osmolality. In true hyponatremia, your osmolality will be always low. In case of hyperlipidemia and hyperproteinemia, your osmolality will be normal. So that is the difference between your true hyponatremia and your spurious hyponatremia. And in some conditions where you have hyperglycemia, in case of DKA, you have hyponatremia, but it's not correct. Their osmolality is very high. To match that osmolality, your sodium is gone down. So once you correct hyperglycemia, automatically sodium will rise. So there you not do much anything. You just correct the glucose levels. So you measure the osmolarity and you think what is the osmolarity. It's a low osmolarity, then it's a true hyponatremia. If it's normal or high, you think of other causes. You don't need to think of correcting sodium there. If it's a true hyponatremia, then you need to think of what kind of hyponatremia it is, whether it is hypovolemic, whether it is euvolemic, whether it is hypervolemic. So hypervolemic causes are very less. So where you have excess fluid in the body, nephrotic syndrome, cirrhosis, heart failure, renal failure. These are the common conditions where you have hypervolemic hyponatremia. And euvolemic, mainly it is SADH. And the causes for SADH, whatever diagnosis you name, they can get SADH. Whatever drug you name, majority of drugs can cause SADH. So there is no like clear cut. This conditions only will cause SADH. This conditions will not cause SADH. Majority of the conditions, especially related to your infections, pulmonary, CNS, any other problem, not only infections, trauma, surgery, so they all can develop SADH. So any child admitted to hospital, the child can prone for SADH. That's what I can tell. So always try to measure electrolytes if any child on IV fluids, especially. In case of hypovolemic hyponatremia, where the losses? The losses in GI tract, or losses in the skin, or losses in the renal. So you need to think of that. So GI losses can be your gastroenteritis, vomiting, and skin losses can be cystic fibrosis and burns. And in dengue, we'll have that spacing. And renal losses mainly because of your diuretics and cerebral salt wasting and renal tubular acidosis disorders. So these are the common conditions which can cause hypovolemic hyponatremia. But what I'm telling is, many of the conditions where you're going to give diuretics, they already will have hypervolemia. So, but clinical signs of hypovolemia will not be visible in them. But there could be a reason for hyponatremia, that element of hypovolemic hyponatremia apart from the hypervolemic hyponatremia. So how much percentage is due to hypervolemia, how much percentage is due to hyper and hypervolemia, you cannot differentiate easily. That basically depends on your clinical features. If the child is having edema, congestion, it's more like hypervolemia still. More percentage is hypervolemic, less percentage is hypovolemic. But if child is dehydrated, then it's most likely hypovolemic than hypervolemic, even with VSD and lung congestion. So that is what these are the common causes. You just go through any book can give the causes. And approach is this: you need to get the history. Then once the history and examination is over, 90% of times you can easily differentiate what kind of hyponatremia I'm dealing with: hypervolemic, euvolemic, hypovolemic, based on history and examination. You don't need for any other test. But like the previous scenario, second scenario, where you have a confusing thing, you have 4 causes for them. So there you need to do some basic workup to know what is the actual reason for the hyponatremia. So there you want to get serum and urine osmolarity, urinary sodium, whether sodium loss are more in the urine or not, blood sugars to see for any hyperglycemias, and in sick child you need to ask for blood gas. So you check the serum osmolarity, and osmolarity is low, then you label it as true hyponatremia. If osmolarity is normal or high, then you have to think of other causes. Once you tell it is true hyponatremia, then you have to think of acute child is having severe symptoms, then you have to treat the child. Treatment is basically, I will discuss it, 3 to 5 ml per kg of sodium chloride, 3% NS. So you need to give it over half an hour. So basically, you need to increase the sodium to a certain extent where the symptoms can ameliorate. If there's no acute symptoms, then you need to see the urine osmolarity. So urine osmolarity is very low, means child is taking more amount of water. So look for primary polydipsia. If urine osmolarity is more, then you have to think of that the child is losing more sodium or there is a hypovolemia element. Then you need to check of urine sodium. You check the urine sodium is less. That means body is to try to conserve the sodium. So that many two conditions where you conserve the sodium is, one is hypervolemic conditions like CCF, nephrotic syndrome, or losses, diarrhea, that kind of situations. They can have low sodium in the urine. Once you have high sodium in the urine, it's clear it is renal losses. Renal losses could be due to drugs like diuretics, or you need to think of renal problems, AKI, and your renal tubular acidosis, this kind of soluble salt wasting. These are the common conditions where you can have renal losses. So basically, this is the approach needed only for less than 10% of the patients where you are very confused with what could be the probable cause for hyponatremia. But many conditions, it is straightforward. Nephrotic syndrome child coming to you on first without any treatment taken outside, it is sure that it is hypervolemic hyponatremia. In a VSD child with a lot of lung congestion edema coming to you, 99% it is hypervolemia. Until unless child is in euvolemic state where the diuretics can be causing hyponatremia. So that's why I'm telling, if you take proper history and do reasonable examination, good examination, if identify child is hypervolemic, euvolemic, or hypovolemic, easily you can figure out what is the cause for your hyponatremia. But in some situations where you have a compounding factors, then you have to think of what is the actual reason. Then you have to check all these things. This approach is not needed for routine patients, only for confused patients where you don't be able to find the answer. So management algorithm, the first thing is hyponatremia. Just look for what is the sodium value, whether child is having very low sodium, less than 120, or child is having symptoms. If child is having symptoms, then you need to correct it rapidly. So you need to give 3 to 5 or 4 to 6 ml per kg of 3% NS till your symptoms improve. Or if child is not getting corrected or symptoms are persistent, then you can give one more dose of same bolus. Or you reach the value of 125. Usually, if you cross the number 125, your symptoms should not occur. If it's occurring, like seizures are not getting terminated even after crossing sodium of 125, you need to think of some other cause for seizures, not the hyponatremia. Usually 99% of times, once you cross the sodium of 125, your seizures should be terminated. If they're not getting terminated, look for other causes, load with AEDs. Nothing you need to do. So usually they'll get corrected with one dose of 3% NS. If not improving, give one more dose, but check that sodium. If the sodium is crossing 125, you need to stop the infusion because that's not the reason for your symptoms. If child is asymptomatic, that is most likely it's chronic. So then you need to think of what is the cause. Whether the cause is hypovolemia, euvolemia, hypervolemia. How will you manage hypovolemic hyponatremia? What is the treatment of hypovolemic hyponatremia?
Fluids.
First we will deal with the shock.
Hypovolemic is mainly because of losses. You need to replace with the fluids. If the child is in shock, you cut the shock. If the child is not in shock, just give the deficit with maintenance. That's why you can correct the hyponatremia. For euvolemic hyponatremia,
Fluid restriction.
so you try to restrict the fluid first. So you start with the 25% restriction, then move on to 50% restriction. If still child is not improving,
Then diuretics.
So no, diuretics not alone sufficient. You need to add the 3% because your diuretics is going to lose the sodium again with the renal. So always combine diuretics with 3% NS. But if your sodium is well above like 130, 135 in between, then you can try diuretics alone. But your sodium is well below 130 and almost reaching 125. Just to giving diuretics alone can deplete your sodium further. You don't know what's going to happen until you repeat it rapidly. So there it's safer to give add on 3% NS. Then you can start your diuretics. The last option is your demiclocycline, where it will block, it will induce the nephrogenic diabetes kind of picture. So you can lose the water. And in hypervolemia, the same, you need to try to restrict, treat the underlying cause, very important, treating the underlying cause. And in case of nephrotic syndrome, you need to try to give albumin, you have to fill the albumin. Until unless you fill the albumin, your sodium cannot be corrected that much. So treat accordingly, mainly restriction of salt and water along with the diuretics. Sometimes you need to combine it with 3%, very rarely 3% is needed here. So moving to essentials with treatment, the most important thing is whenever you're giving 3% NF corrections or dealing with hyponatremia children, restricting fluids, where sodium is very critical value, you need to repeat it every 4th hourly. Unless you have a facility for repeating sodium 4th hourly, never ever treat severe hyponatremic child in your institute. That is, you're going to do more harm for the child than benefit. And your target serum sodium correction is 8 to 10 in 24 days. Basically, you are giving time for the body to adjust to the rapid rise in osmolarity. So it try to get back so whatever it excluded back. So your proteins, phosphorus, the cell has to get back. So you need to give certain time for the cell to get it back. So if you rapidly increase the sodium, it cannot get it back that much rapidly. So your osmolarity will be rising in the plasma. It can cause shrinking of the cell. That's why the maximum target of sodium correction is 10 millimoles at any cost per day. In symptomatic hyponatremia, your risk of morbidity due to delayed treatment is greater than risk of osmotic demyelination. So there you cannot think all these things. It could be chronic hyponatremia itself, but the child is having continuous seizures. There you cannot follow this logic of correcting. There you have to give rapid sodium correction. Then the remaining correction you have to give it very slowly. So that way you can deal. And hyponatremic seizures will be refractory to ADs. They cannot be controlled. You keep loading 3 or 4 ADs unless you increase the sodium to a certain extent, they are very refractory. So that's why don't delay sodium correction in hyponatremic seizures. And most important thing is you need to strictly follow fluid balance. And most importantly, daily weight check. That is what will tell you what is going to happen with the fluid status of the child. The child is going towards euvolemic and hypervolemic side. And most important thing is you need to treat the underlying cause. So how to prevent hyponatremia due to SIDH? So always try to give only isotonic fluids. So in our unit, we stopped using half DNS. So we stopped using for last 6 years. We stopped using half DNS. We are using only DNS, even for normal maintenance for any ward children as well. And we never give maintenance fluids. We're going to give only 2/3. So even if a child is hyponatremia, then we're going to restrict it further. So always try to give 2/3 maintenance fluids and isotonic fluids. That's where you're going to prevent the hyponatremia due to SIDH. And always try to measure the electrolytes baseline, then monitor daily eventually some full IV fluids and regular weights. These are the things, essential things you need to follow in admitted patients to prevent hyponatremia due to SIDH. So this scenario already discussed it. So I'm not going to discuss again this. This first scenario is hypervolemia, second scenario is euvolemia. So you are going to restrict the fluids first. If no improvement, then you can try to give some amount of 3% NS and then you start gases. So then I need to get the answers for this scenario from you. So now I won't talk, you people have to talk. So 7-day-old neonate, multiple episodes of bilious vomitings. So child was on EVM and related cosmics as well. And on admission, child is having dull and recurrent apneas are there. Eyes are sunk and severe signs of dehydration are there. Child is in shock. Birth weight was 3 kg, current weight is 2.5 kg. So what is the cause for hyponatremia? Now you're going to manage. I need the answers here. This is what your sodium. Come on.
Maybe it's in severe acidosis. Severe
Oh.
dehydration with acidosis, metabolic.
No. The first question here is what is the cause for hyponatremia? That's all.
Severe dehydration, hypovolemic hyponatremia.
Hypovolemic
Vomiting.
hyponatremia. So what you are going to do with this child now?
Dehydration correction.
How? So what is the first question here? When you have abnormal electrolyte, what is the first question you have to ask yourself?
Whether is it true or
Yeah, whether the sodium, whatever value you got is true. Is it true value here?
yes,
Why? What is true value?
because the child is sick and
So okay, any child can be sick. That doesn't mean child should have low sodium.
Loss is present.
Yeah, there is an underlying cause. Child is having multiple episodes of bilious vomiting from day 3 onwards. So there is a losses, some losses are there which can explain hyponatremia. But the most important thing here is not about only losses, there is symptoms. The child is having
Apnea.
symptoms of hyponatremia. Child is dull and having apnea. So in this context, where there is a cause which is explaining hyponatremia, symptom which can be attributed to hyponatremia, we cannot think of spurious here. Understood? So this is not a situation where you need to think of spurious. That is a true hyponatremia. The next question arises. What is the next question?
acute or
No, before that.
critical.
Exactly. So is it critical? So is it critical or not?
Critical.
Yes.
Child
In case of critical,
shock.
what do you need to do?
Rapid correction.
So how are you going to cut rapidly?
Bolus of
Bolus.
normal saline.
Okay. How many want to give normal saline bolus here? I'm not talking about shock correction. I'm talking about sodium. Anyway, you're going to give 3% sodium bolus for this child to correct the shock. But what about sodium? Child is having apneas. So how many want to give 3% as this child?
First, initially, cardiac part should correct first because of pulse is feeble, tachycardia.
Yeah, I'm 100% happy. The first answer here is sodium bolus. I'm not denying the fact that you need to cut the shock. You are going to give the sodium bolus. Then what I'm asking is, what is going you are going to deal with apneas? What you are going to deal with the sodium of 115 here?
Per se in NS also there will be sodium, but after giving bolus, you have to repeat again electrolytes. Based on that, again.
How much time you going to get the electrolyte report in your institute?
We have ABG machines. We will see there.
The patients are that much affordable to take ABG 5 minutes late. No, I'm just asking. Is it how much is the ABG cost? So the point here, what I'm telling is, you cannot keep repeating values frequently, half an hourly or hourly. So if you give NS bolus, I will do sodium. Absolutely fine. If you're affordable patients, you're working in institutes where you get a ABG at the bedside and you can repeat all these things simultaneously, absolutely true. What you're telling is 100% correct. But what I'm talking is a sector where you cannot have luxury of ABG machine at the bedside, and you cannot get a sodium value within half an hour or 1 hour. So just think about that kind of scenario and just answer your things. So I'm not talking about a corporate hospital where you get an ABG machine on the bedside and 5 minutes you'll do one more ABG, one more ABG, one more ABG, and then you can decide. That's the ideal thing. But that will cost the patient more and the patients are unaffordable. Absolutely contraindication to do ABG that frequently. In the government sector, what I've done in government sector and peripheral sector, where you get this kind of children at the first instant. If this child is being referred to a tertiary care center, that's a different scenario. But the first contact cannot be tertiary care center. The first contact can be a primary or a medical college. So where the facilities are not there, so what they can do? That's what I'm asking. So absolutely, you're going to give 3 NS bolus, I'm fine. But what about 3% NS? Is there any contraindication 3% in this child?
No.
Yeah, that's what I'm telling. So try to give some amount of 3% NS here. I'm not going to tell you to give directly 6 ml per kg here, because already you're giving sodium through NS. You need to give that much amount. Try to give some amount. You want to give 2 ml, 3 ml per kg, that is fine for me. So understood what I'm telling? So try to give some amount of bolus, 3% NS, and apart from that, you can continue on NS bolus and you correct your shock. So everyone agree with the point what I'm telling? I'm talking about resource limited settings. I'm not talking about resource well resources settings. So there the harm for your hyponatremia causing neurological damage is more than your 3% NS bolus. So that's why I will follow that logic in treating this kind of children where you have limited resources. Next, okay, I given 3 ml per kg, 3% NS, I given NS bolus. So what are you going to do next? Tail is better, no apneas. Shock getting corrected. So what are you going to do now?
Slow correction now, sir.
What correction? How to slow correct? You want to give 3% slowly?
No, sir, we should choose our fluid.
Yeah, tell me what is fluid you're going to give here. This is a hypovolemic hyponatremia patient because of vomitings, came in shock, you give a fluid bolus, shock get corrected, you give on 3% NS 3 ml per kg, with that child become alert and now apneas now. So what you're going to do next?
Further correction depends upon the next step to get value, sir. Because already we have given fluid bolus and 3% NaCl. So how much amount of sodium is raised? Because per day, not more than 10 milliequivalent should rise.
Absolutely. Okay, fine. Now, immediately what are you going to do? I know resource setting, I cannot get the sodium after 4 hours, I can get it.
Or maintenance NS.
Yeah. No? Yeah.
1.5 times of maintenance fluid, sir, we can start.
Hypovolemic dehydration, how are you going to correct? Sorry, hyponatremic or normonatremic dehydration, what is the principle, what we discussed in the last previous videos? You're going
Deficit plus maintenance.
Deficit plus maintenance. How much deficit you're going to correct in one day?
Dehydration.
Hyponatremic and normonatremic dehydration, how much deficit you're going to correct in one day?
10 milliequivalent per day.
You can correct it fully. That is what we discussed. So you need to correct it over 24 hours, not like 6 hours in WHO protocol. Only in hypernatremic dehydration, you need to correct it over 48 hours based on the sodium value. But in hyponatremic and normonatremic dehydration, you can correct it over 24 hours. But what type of fluid you're going to choose depends on your sodium rise. In this child, if you don't get immediate sodium, what is the fluid you're going to start immediately?
DNS.
Exactly. On DNS, you need to repeat the sodium. You repeat sodium after 3 to 4 hours. You check what is the sodium rise. Based on that, you need to adjust your fluid. You want to come down to 3/4 NS. You want to come down to half NS. That is up to you. but you cannot change the fluid rate here because your main aim is here to cut the dehydration. Your sodium is automatically getting corrected, but if you cut down the fluid based on because sodium is rising rapidly, your dehydration will not be get corrected. That's why whenever your sodium is rising rapidly, you need to cut down the concentration than cutting down the fluid initially. But even if you shift it to half NS and your sodium is cutting rapidly, then you need to cut down the fluid rate. I hope I'm clear what I'm talking. So in this child, I'm going to start DNS. That's all. There's no doubt in this. I will start DNS, deficit plus maintenance over 24 hours. Then I'll keep checking the sodium values based on the next sodium values. If it's correcting very rapidly, I'm going to cut down my concentration. If it's correcting according to the plan, I'm going to continue same. Clear?
Yes.
So this is what we discussed previously. In case of hyponatremic and hyponatremic and eunatremic dehydration, you need to give the bolus to maintain the shock. Once you correct the shock, you calculate the fluids, maintenance plus deficit. And whatever the boluses you given, you subtract from this and you give it as DNS, not half NS. You need to give it as DNS and you need to keep repeating the sodium. Then based on that, you need to change your sodium concentration in the fluid. So this is the case scenario 3. Already discussed this. So now what are you going to do? Tell me. The child is asymptomatic. Sodium is 121. Causes are multiple. Hypervolemia, euvolemia, hypovolemia. Is it true hyponatremia? What, man? No answer.
So it is hypervolemic.
Hypo. Hypervolemia.
First leave all that. Is it true hyponatremia?
It's true. Sir.
Yes.
Perfect. Next, is it critical?
Yes, sir.
Yes. Irritable. Child is irritable, sir.
Irritability is a symptom of hyponatremia.
Yes.
Okay. It's not a symptom of hyponatremia. Hyponatremia symptoms are changed lethargic to the updated phase. Irritability is very less finding. It's not very related to the irritability is mainly because of your distress rather than your hyponatremia here. And see here, the child can have symptoms like fever for last 2 days and changes in medication. So everything is going towards chronicity. In chronicity, sodium 121 will not cause much symptoms. So I don't feel this is a critical value per se right now because child is not having any symptoms. If the sodium value is 119, is it critical?
Sure.
Is it critical or not? If sodium value is 119.
Critical, sir.
So there you need to give at least 2 ml per kg or 3% NS to get it above 120. Even child is asymptomatic. If child is symptomatic, your target is 125. I hope I'm clear on that, what our target critical values means. So all agree this is not critical sodium. Any questions on that?
The critical depends upon the irritability. It depends upon the sign, sir. Even
Yeah.
chronic sodium in chronic hyponatremia, child will be normal. So we can't consider them as critical.
That's what I'm telling. Sodium less than 120 is critical value. That is what the guidelines given. That is not my guideline, that is the regular guidelines. What they're telling is any sodium less than 120, there's a chance for CNS morbidity. They can develop symptoms. That's why you cannot leave a child in sodium less than 120. You need to, that's a critical value. You need to treat it. There you need to give some dose. I'm not talking about 5 ml per kg. I'm talking about, you think like sodium is 180, you target is 120, give 2 ml per kg. So that less than 120 can cause symptoms at any point of time. We cannot leave the child like that because child is asymptomatic right now. I'll just wait and watch. So that is not possible when sodium is less than 120. But the same child having sodium of more than 120 without any symptoms, then you can wait and watch. You can correct it slowly. But same child having symptoms with sodium less than 125, you need to consider critical. You need to treat it. You need to give some amount of 3% NS to take it to the near value where symptoms can be reduced. So say 125. So this is what the guidelines are telling. So you can go through the guidelines and you can get a reference where they're telling you should not treat a sodium of 118 when there's no symptoms. Whatever guidelines I checked out, they're telling less than 120 is the critical value. You need to correct it at least to take to 120. That's what my professors and my teachers.
Sir, good evening, sir.
Yeah, hello.
Hello, sir.
Yeah, please.
Sir. Hello, sir.
Yeah, I'm audible. Or audible.
Yes, sir. Yes, sir. Yes, sir.
You want to ask something? Okay. So how you going to manage this cell now? Your sodium is 121.
Restrict fluid 1/3.
Perfect.
Fluid restrictions are first.
You are going to restrict the fluid. Yeah.
Add 3% NS in feeds.
You want to add 3% NS in feeds. Okay. You want to take a gamble of restricting the fluids and wait and watch in this child? No, I'm just asking. You feel that it's safer to wait and watch with sodium of 121 in this child by just restricting the fluids and adding.
Already loose stools are there, 3-4 episodes. So
Explain.
sir, already loose stools are there, 3-4 episodes per day. Then we are restricting fluid more.
Yeah.
So I think we should correct also. Apart from like restriction, we should rather go for correction because already fluid loss is there, although less, but it is there.
Okay. How much you want to correct? How much sodium you want to correct? You want to correct till 135?
125, sir. Then we can wait and watch.
How much fastly you want to correct?
So no need for fast correction. It feels like a chronic thing happening because of anti-failure medication might be the cause, one of the cause.
Yeah, there's a lot of causes there. It's not only single cause, there are 3-4 causes are there. So my point here is you cannot sit right on a sodium of 121 because child is asymptomatic. So child had evidence for losing more amount of sodium because of diarrhea, or this child is going because of distress, you're going to give Lasix again. You're going to stop furosemide in this child at this current junction?
No, sir.
Because you already crepes are there, distress is there. So you are going to, at least you're going to give, because of congestion in the X-ray and cardiomegaly, definitely child is need further diuretics. And it can tilt the balance, you can drop the sodium further. So it is not safer to wait on this child. No, if you have facility to monitor sodium frequently, the answer can be yes. You can restrict the fluids, you see what is the response, afterwards repeat, then you can check. Then, but you are in a resource settings where you cannot do frequent monitoring of sodium. It's always better to correct it slowly. I'm not going to tell to correct it 10 milliliters per day. You correct 5 milliliters per day. You target 5 milliequivalents, then you repeat sodium, then you see. So you correct 5 milliequivalents over 1 day. That's what I'm telling. If you target 5 milliequivalents per day, if restrict fluids, then you can get sodium a little bit extra, like 8 to 10 milliequivalents. But for that, you cannot think like that. You need to repeat sodium at least once or twice in a day to see it is going in the same direction, or sodium is dropping, or sodium is rising rapidly. Based on that, you need to adjust your volumes. Is it clear what I'm telling?
Yes, sir.
Talking about resource limited settings where you cannot monitor sodium hourly or second hourly. And in this particular child, I cannot sit right on a sodium of 121. So what I'm going to do is I'm going to start a 3% NS correction, and I'm not going to target of 10 milligrams per day. I'm going to target it only 5 milligrams per day. And rest, I assume that my fluid restriction and diuretics can do the job for me. The next question is, if I decided to give 3% NS for this child, now the question is to correct 5 milligrams per day, how much so 3% NS infusion I want to start per hour? How to know that?
0.6 into weight into expected correction.
What is that? What is going to get by doing that 0.6 into weight into correction weight? What you're going to get? You are going to get sodium deficit. That is the formula for sodium deficit, right? So there are a lot of things previously, and so many books give so many approaches: sodium deficit, water excess. So these are all things only for very, very highly knowledgeable and intelligent people, not like me. I will never think about sodium deficit, volume excess, how much 3% I has to give. I will not calculate. I won't use that much brain because I am not that much knowledgeable person. So I choose in a very safer approach for this. So there is a lot of calculator already available in the internet. So they'll make my job easy. So they won't stimulate my brain too much and consume the energy. So just follow these algorithms, what is already given in the net. So in that, only thing is you need to select the age and sex, and you put the weight in kg, set serum sodium, and you can choose. What you have to choose here is rate of sodium correction. So if you want to correct 10 millimoles per day, what is the rate you have to keep here? You want to correct 10 millimoles per day. So what is the rate you have to keep here? Rate of correction per hour. This per hour.
0.4 almost.
Yeah, roughly around 0.4. In this particular child, my target is only 6 milliequivalents. For 6 milliequivalents, what is the rate I have to keep here?
0.3.
So roughly around 0.25. So once you put 0.25 here, and you need to select the what type of fluid you want to infuse. You can correct hyponatremia by giving normal saline, 3% normal saline, and even ringer lactate. But you cannot go for half NS. Even you can correct hyponatremia giving half NS. I'm telling again, don't think otherwise. I have managed many children by half NS as well. Hypovolemic, hyponatremia, they can easily be corrected with half NS also. But in this particular child, it is not hypovolemic. Here it is more of hypervolemic and euvolemic. That's why you need to give less fluid. But if you select NS and half NS, you need to give more amount of fluid. That's why they are not advisable. That's why you need to go for more concentrated fluids. So I selected 3% NS here. So what it given? It given 5 ml per hour. So this is what the result you're going to. You no need to calculate anything here. Just you need to put some values. What are the values the patient is having, and how much is the rate of correction. This is what you have to select. How much is the rate of correction? You select that parameter, and you get the result. You just put that much in the infusion pump. And most important thing is just putting this rate is not sufficient. By putting this rate, your sodium can correct very rapidly. Sodium can decrease, or sodium is not getting corrected that much what you expected. That's why always monitor sodium 4th hourly minimum. That is the minimum duration. You cannot. Minimum is maximum duration. If you have resources and patients are affordable, you can cut hourly, monitor hourly also. So you should not delay the second sodium repetition not more than 4 hours. So once you put the formula, you started infusion, you need to check the next sodium not more than 4 hours. You have to repeat the sodium. And based on that sodium, you need to try to adjust your rate. You want to decrease the rate, increase the rate, continue the same rate. based on your second sodium, not on the first sodium. So based on the first sodium, you titrated and you came to the conclusion that I want to give 3% NS. How much? 5 ml per hour. With this, how much is the sodium getting corrected? The sodium is getting corrected, not getting corrected, then what I expected, or sodium is decreasing. Then you need to revise your formula. Then again, you need to recalculate it again. Then you need to put the value there. So this is easier for us to put. So we'll stop here. Any questions is there, we can take. Otherwise, we'll end the session. The rest of the para electrolytes we will discuss in the next session. It's freely available. You can download the app also. Medcall Cap. This is called Medcall Cap. It is easily available in even your phones. You can download the app. So there are so many corrections available in it. You don't use your brain at all. Don't need to remember all the formulas at all. So just download this Medcalc app and you can correct what you can use. What are the formulas? What they're going to tell? It's automatically it will use that formula. It's going to calculate for you. So I strongly suggest all of you to download this app and install in your mobile. No questions. We'll end the session.